Words are powerful, and I think that also needs to be, you talked about educating a lot of people, and I try to educate patients in that manner as well. Not as forceful, but just saying, and like, we know what we're doing. We know what we're talking about, and we know we're here for you to be an advocate, but we also are here to educate and bring you the best quality care, orthopedically, neuromuscularly speaking, as possible. And I think there's a lot of confusion. So I guess for people who are listening to this and they're like, okay, well, who should I see? A primary care doctor, or should I see a physical therapist? I guess discernible difference in my mind. I'm like, okay, if aches and pains, see a PT. Other than that, if it's something related to your heart or something else, go to primary. Would you use that as a way of kind of discerning between the two? Or I guess, what's your viewpoint?
Yeah, so I think that's reasonable. I mean, I think that's a reasonable discernment. I mean, the challenge is most patients aren't going to know whether or not their back pain is from something musculoskeletal or something non-musculoskeletal, right? However, if they come into something with something non-musculoskeletal, whether it be, a AAA, or whether it be cancer or things like that, we are uniquely skilled to be able to screen that out, right?
Yeah.
So as a physical therapist, our first step should always be triage. Does this patient belong to me? And this is true of whether or not they've been referred to you or not. The very first thing we should be figuring out is, does this patient belong to me? Is it something musculoskeletal? Is it not musculoskeletal? Should I treat this patient, or should I refer this patient while treating them, right? So for instance, in the case of the ACL I talked about earlier, yeah, I'm referring them on for imaging and I'm referring them on for orthopedics, but simultaneously I'm still doing some treatment stuff to kind of work on edema and whatever else. And truly, in the grand scheme of life, I'm doing that more to just make sure the patient is still plugged in. And I'm doing it more from a management standpoint necessarily than a treatment standpoint. But you can have that treat refer, or you can have the purely refer, right? This patient does not belong to me, right? And I had an interesting one. It was a patient that came in and he was 23 years old. And his primary complaint was ankle swelling, not pain, but just swelling. And he took off his boot, and it was atraumatic ankle swelling. And when he took off his boot, his ankle was purely effused. There was no edema; it was just an effusion. And I'm like, wow, I don't know anything orthopedic that would cause an acute onset of atraumatic ankle effusion in a 23-year-old.
Right.
I mean, there aren't a whole lot of orthopedic things that'll do that. So, at that point, I didn't know exactly what he was, but I knew he wasn't for me. He wasn't mine. So at that point, that was a pure refer, and I tapped his primary care provider and I said, look, I don't know what's going on with this guy, but I just know he doesn't belong to me. And so they ended up ordering an erythrocyte sedimentation rate, which is an inflammatory marker, which was off the charts. They ended up doing some more things, and what it turned out to be a gonococcal infection, which not a lot of people are aware, but when you get gonorrhea, the common location for it to go to is actually the ankle.
Oh, wow.
As a location. So that's what happened with this young guy. He had gonorrhea. It went to his ankle, and that's what kicked it all off. So ultimately, as physical therapists, at least in an outpatient orthopedic setting, which is probably outpatient orthopedics is probably the primary care of physical therapy, if we're really true. When you get into some of the specialties like pediatrics or neurology, at that point, it might already be clear that the patient has cerebral palsy or a stroke or whatever else. But orthopedics is a mixed bag. You never know what's going to come in on any given day. So from an orthopedic standpoint, if as a physical therapist you are treating every single patient that comes through your door, that should be concerning to you. That should be a red flag to you. You probably shouldn't be. There's probably someone that's coming in that doesn't belong to you, and you're treating them anyway. And that's that technician mindset, right? Or if you're treating everybody for 14 visits, right? That's probably a technician mindset, right? And that might be a great business model, but from a medical necessity standpoint, that doesn't make a ton of sense. So I think that I think that that's where we need to go as a profession.
Yeah, and humility, you got to have humility and understand that sometimes you can't treat every single patient,
Yeah.
and sometimes you got to be able to reach out to somebody else who may know more than you. And I think that's a humbling thing to admit to yourself, and that's something that you have to experience in order to do so. But I think once you do that, it opens doors to understand like how the profession should be conducted, and realize that there's other options, and you're there for the patient. And so if you saw them for a month, 3 to 4 weeks, and things aren't getting better for, again, let's say insidious low back pain, again,
Mhm.
maybe there's another clinician out there who knows what they're doing, and or doing something different that you don't know, and you can learn from that. And that's super important. And I think having humility is a huge step in that direction.